So turning indeed to the dark side, our next speaker is George Koob, who is Director of the National Institute on Alcohol Abuse and Alcoholism. Before assuming that post, he was a professor at the Scripps Institute and chair of the Committee on the Neurobiology of Addictive Disorders there. Dr. Koob is well recognized for his seminal work on the interactions between abused drugs and brain circuits involved in negative emotions and stress. He has also won many awards and recently became a Chevalier of the French Legion of Honor. I'm very much looking forward to his talk.
Hello, everyone. I'm going to talk today about opioid addiction, opponent process, hyperkatifia, and negative reinforcement. What I'm really going to talk about is the role of emotional pain in addiction and its relevance to the interface between pain and addiction. We know that there is a dramatic crisis in drug abuse in this country, and particularly in opiates. There is an opioid crisis, increases in opioid overdoses that have been going on now for over 10 years. But there's also an endemic alcohol crisis. And when you look at the numbers associated with alcohol of 14 million individuals with an alcohol use disorder versus 2 million of individuals with an opioid use disorder, you can see that it's basically alcohol addiction. I call the addiction that everyone knows about, but no one wants to talk about. And I want to point out that we lose about 90,000 people a year to alcohol, and alcohol accounts for about half of liver disease now in this country. And these two drugs contribute to what we know as the mortality, drugs, and deaths of despair in the United States. Morbidity and mortality, termed the deaths of despair, have been increasing in the midlife in the United States from around 2000 to 2013. And this is illustrated in the right-hand slide, a part of this slide showing that there's an increase in mortality in white non-Hispanics between the ages of 45 and 54, increases in poisonings, increases in suicide, increases in chronic liver disease, all of which can be attributed to drugs. And this is the now famous paper of Ann Case and Angus Deaton, published in PNAS. And these patterns of increased mortality have also now been observed across many racial and ethnic groups and age groups, as shown by a recent study published by Wolf et al. That drugs and alcohol play a prominent role in these deaths of despair. Alcohol contributes, for example, to 15 to 20% of all drug overdoses, to about a quarter of suicides, to half of liver disease deaths, as I pointed out before. And these deaths of despair are contributing to the decreasing life expectancy in the United States observed since 2014. So my talk will follow the following outline. I'm going to talk about the dark side of addiction, conceptual framework, opponent process, hyperkatifia, and negative reinforcement. I'm going to then talk about neuroplasticity in the brain negative emotional circuits, notably loss of reward neurotransmitters and gain of stress neurotransmitters. And finally, I'm going to talk about the overlap in the brain negative emotion and pain neurocircuits, implications for the role of addiction in deaths of despair, and the effects of the COVID-19 pandemic. So let's start with the conceptual framework. So I define addiction as a chronically relapsing disorder that is characterized by a compulsion to seek and take drug or stimulus, loss of control and limiting intake, and emergence of a negative emotional state, dysphoria, anxiety, irritability, when access to the drug or stimulus is prevented. And this latter part I call the dark side of addiction, and is a Koob add-on to what most people would use in their definition of addiction, which is compulsivity and loss of control over intake. The framework that this addiction definition fits within is a framework of 3 stages. It's a heuristic framework. And so the 3 stages are the binge intoxication stage, the withdrawal negative affect stage, and the preoccupation anticipation stage, or craving stage. These represent 3 different domains of dysfunction. In the binge intoxication stage, incentive salience and pathological habits emerge. In the withdrawal negative affect stage, reward deficits and stress surfeits or increase in brain stress and hormonal stress systems in the body emerge. And in the preoccupation anticipation stage, executive function deficits emerge in that particular stage and continue into protracted abstinence. These three stages, as you can see from the diagram, are color-coded for different circuits in the brain. So binge intoxication is largely mediated by basal ganglia and striatal, palatal, thalamic, cortical loops. I'm not going to talk about the binge intoxication stage today. The withdrawal negative affect stage, in contrast, are the red bits that belong to the extended amygdala. And I will spend a little bit of time talking about that in the second part of my talk. And then the third stage, of course, is the craving stage, and it's largely mediated by cortex and allocortex, old cortex. But the cortical part that's most heavily implicated in the craving stage, of course, is prefrontal cortex. So I want to move to the dark side of addiction, as I call it. I want to talk about the framework for the withdrawal negative affect stage. This is one of my favorite paintings by Picasso, The Absence Drinker. At the turn of the 18th to the 19th century, most of the Impressionists did a painting of individuals drinking absinthe, and none of them have a smile on their face. So that's, I guess, part of the point of this painting. But in another conceptual framework that had a dramatic impact on my thinking came from Richard Solomon at the University of Pennsylvania many, many years ago. He called it a standard pattern of effective dynamics produced by novel and repeated unconditioned stimulus. Today we call it opponent process, or if you want it in simplistic terms, what goes up must come down from a hedonic perspective. If you look at the left-hand panel over here, you see what is called a hedonic response to an opiate drug, which is the A process here is getting high or feeling very, very good. And that's followed when the drug wears off by a B process where you feel dysphoria. However, when you're dependent on an opiate, as Solomon hypothesized, you lose the A process and you gain the B process. And what I'm going to argue later is, in fact, that the B process gets larger and larger, and that's what accounts for this loss of the A process or tolerance. So I've spent a good part of my second part of my career studying this opponent process. And I described it as a hypersensitive negative emotional state associated with withdrawal from drugs. And I got tired of writing hypersensitive negative emotional state, so I made up a word. It's called hyperkatifia. It's defined as the increased intensity of negative emotional, motivational symptoms and signs observed during withdrawal from abused drugs. It's derived from the Greek word katifia for dejection, sadness, or negative emotional state. Hyperkatifia is hypothesized to represent elements such as dysphoria, irritability, alexithymia, or simply symptoms often described as ill at ease, uncomfortable within one's own skin, or simply not hedonically normal, symptoms historically difficult to define. Basically, I was paralleling the term that's used widely in pain, a field known as hyperalgesia, which is increased sensitivity to pain. This is increased sensitivity to emotional pain, or hyperkatifia. And this brings me to a final theoretical construct and source of motivation in addiction that's often neglected, and that is of negative reinforcement. Now, everybody knows what positive reinforcement is, defined as the process by which presentation of a stimulus, in this case a drug, increases the probability of response. But negative reinforcement is defined as a process by which removal of an aversive stimulus, and I'm going to argue a negative emotional state of drug withdrawal, or removal of hyperkatifia, increases the probability of a response. It's important to distinguish negative reinforcement for punishment, because punishment is actually a suppression of behavior, but negative reinforcement is an increase in the probability of a response by removal of this aversive state. And when you put this all together, you can come up with a framework that I borrowed from Lauren Parsons many years ago, where you see positive reward, positive reinforcement as having a key role in the early stages of addiction, but the negative reinforcement kicks in, and the relief of negative reinforcement being a motivating factor that continues drug seeking and drug taking behavior. And then protracted abstinence, which can loop back to either one of the earlier stages of the addiction process. And so you can argue that the loss of control and compulsivity associated with addiction derives from development of incentive salience and pathological habits for drugs, development of reward deficits and sensitization of stress neurocircuits, and compromised executive function. Again, following the 3 stages of the addiction cycle. And I want to make one other point. While the cycle is not on this slide, you can enter this cycle from any one of these different stages. You can imagine even that someone would enter from the impulsivity side because of already compromised executive function, because of already trauma early in life. Now I want to drill down a little bit, and I'll show a little bit of data on the neuroplasticity in the brain negative emotional circuits. So this circuitry is called the extended amygdala. The focal point is the central nucleus of the amygdala, but it includes the bed nucleus of the stria terminalis and a transition zone in the nucleus accumbens, which is labeled here as NAC. Bed nucleus, stria terminalis here, and the central nucleus of the amygdala. This circuitry is hypothesized to mediate negative affect, the signs and symptoms of hyperkatifia that I've described, but it's also hypothesized to involve changes in neurotransmitters in this circuitry, notably loss of dopamine and opioid peptides, but gain of the brain stress neurotransmitter systems. And I'm going to talk about some of those in a minute. But I just want to point out that this argument is that the opponent process is mediated by 2 different effects at the same time within the extended amygdala. The loss of reward function, the reward deficit, and a stress surfeit, the activation of these brain stress systems. And again, I've illustrated the neurotransmitters involved on this slide, but I've also shown you the hypothesized increase in the B process that I would argue, based on the theoretical position of people like Francis Colpert and Richard Solomon himself, would be subtracting out the A process and creating tolerance. So a long time ago, Floyd Bloom and I conceptualized that addiction had 2 neuroadaptations. One we called a within-system neuroadaptation, and we defined that as a process by which a primary cellular response element to the drug would itself adapt to neutralize the drug's effects. Persistence of the opposing effects after the drug disappears would produce the adaptation. And we know in addiction that all drugs of abuse, when excessively used, produce a loss of dopamine function during withdrawal. And this is a good example of this from 2 published papers early on, showing that if you give a rodent daily injections of morphine and follow them with naloxone and precipitate a very aversive withdrawal state, that you see a time-related decrease in release of dopamine in the nucleus accumbens. And this is observed in 2 different studies, one with morphine pellets and one with daily morphine injections. But what I really want to focus on, and which has been the focus of my research, is on what Floyd and I called the between system neuroadaptation. And this we defined as a process by which a different cellular system and separable molecular apparatus would be triggered by the changes in the primary drug response neurons and produce the adaptation. So we're arguing there's another circuit that actually is recruited to act in opposition to the overactivity of the reward circuit. And really this came from the on and off neurons associated with pain that Howard Fields was studying many, many years ago in the brainstem. And so one of the neurotransmitters that are implicated in this between system neuroadaptation through a wide number of different drugs of abuse, but including opiates, is corticotropin releasing factor. And I had the privilege of working with Wiley Vale when CRF was discovered at the Salk Institute in 1981. And we know now that CRF basically drives the body's stress response, not only the hypothalamic pituitary adrenal response to stress, but also the brain response to stress. And you can see that CRF is highly represented within the extended amygdala. These are cell bodies for CRF in the central nucleus of the amygdala and the bed nucleus stria terminalis. And you can see down here in this table that we know now that during withdrawal from all drugs of abuse, there's an increase in CRF and release in the central nucleus of the amygdala. And we know that CRF antagonists can block withdrawal-like and anxiety-like aversive responses in animals. We know that that CRF antagonists can block dependence and induced increases in self-administration and escalation in self-administration. And we know that CRF antagonists can block stress-induced reinstatement in animal models. And just to give you a quick example, this is data from Paula Park, my last PhD student at UCSD. And she showed that a CRF1 antagonist, MPZP, which was developed at the Scripps Research Institute by Kim Janda, would block, when given on a daily basis, would block the escalation in heroin intake that is associated with extended access to heroin. And so if you look at this slide, you can see that animals that have extended access to heroin and then they have the weekend off and then extended access to heroin and the weekend off, that these animals would are slowly escalating their intake of heroin. They're taking a large amount of heroin in a 12-hour session, but the animals pre-treated every day with the CRF antagonists show a block in this escalation of intake that we see with basically unlimited access to opiate drugs. Another neurotransmitter implicated in this hyperkatifia, in this negative emotional state associated with withdrawal and having a very similar profile to that of CRF, is dynorphin. And a long time ago, Bill Carlazon and Eric Nestler hypothesized that overactivity of the brain reward system could drive cyclic AMP response element binding protein, to produce more dynorphin release, which fed back and shut off the dopamine system, for example. And we now know that dynorphin is also localized in the extended amygdala, and we know that dynorphin expression is increased during acute withdrawal, and we know that kappa antagonists now can block withdrawal-induced anxiety and aversive responses, can block dependence-induced drug taking, and can block stress-induced reinstatement of drug taking. And just to illustrate this in a very dramatic way, repeating the escalation in heroin experiment in the blue here, you can see that the animals with extended access to heroin taking an enormous amount of heroin over repeated sessions. If they are pre-treated with one single dose of NorBNI, a kappa antagonist with a very long duration of action, you can see it blocks the escalation in intake and it blocks responding on a progressive ratio schedule for heroin. I just want to point out to you that NorBNI is effective for up to 2 to 4 weeks after a single injection. It's not at all clear exactly why that occurs, but probably has to do with some transduction mechanism that changes the internalization of the receptor. And I want to point out to you that during withdrawal, daily withdrawal, if we sacrifice the animals during the withdrawal from their escalation in heroin intake, we see an expression of dynorphin, an overexpression of prodynorphin in a very specific area of the shell of the nucleus accumbens. And then if we microinject NorBNI directly into that shell part of the nucleus accumbens, we replicate the effects of a systemic injection of the kappa antagonist. And so you see the same blockade of escalation and the blockade of the progressive ratio schedule. And so I could spend a lot of time going through each one of these neurotransmitters on the left-hand side that are implicated in what I call the stress circuit associated with hyperkatifia. Ones that I haven't discussed are norepinephrine, vasopressin, orexin, /hypocretin, substance P, glucocorticoids, and neuroimmune factors. And I just want to mention very quickly that in addition to these stress surfeit neurotransmitters, there are stress buffer transmitters that actually may help bring this stress system back into a more homeostatic-like state, notably neuropeptide Y, nociceptin, yes, endocannabinoids, and even oxytocin. Now, finally, I'd just like to wrap up by talking about my third piece, which is the overlap in the brain negative emotion and pain neurocircuits, and the implications of this for the role of addiction in deaths of despair and the effects of the COVID-19 COVID-19 pandemic. And what I'm referring to is the social isolation that was a necessary byproduct of the pandemic. And I'm going to switch to alcohol for 1 second and just mention, in putting on my NIAAA hat, I just want to remind you that we occasionally have presentations on Capitol Hill to the staff of congressmen. And Martha Woodruff was part of one of the presentations we did where we were talking about women and alcohol. And she gave such a wonderful talk. I asked her whether I could get a quote from her, and Martha, who's a former public radio journalist and late blooming novelist, wrote the following, and so that's what's in this slide. I grew up professionally focused and personally adrift. There's a long history of depression in my family, and my childhood home was dominated by my mother's mental illness. It was not recognized, let alone treated. Sometime in my mid-30s, I started using alcohol to provide relief from the pain of childhood damage and organic depression. Bourbon was the only thing that would make the loop tape of despair in my head pipe down. So I want to remind you that while opiates are God's gift to medicine when it comes to acute pain, opiates can also cause pain. And opioid withdrawal-induced hyperalgesia has been well demonstrated now in the literature. This particular study was in heroin-dependent individuals where they looked at drug history on ischemic pain threshold and tolerance. They used a tourniquet procedure, a standard blood pressure cuff. They looked at individuals during acute withdrawal. These are human beings, 24 to 72 hours after their last heroin dose, and ex-users 30 months after their last heroin dose, 30 months. And if you look here at the slide, you can see that there's decreased threshold for pain in the acute withdrawal group, but it remains even 30 months later. And this has often been described in the literature. And the same goes for pain tolerance. And I just want to mention that alcohol does the same thing. And this was a group of 30 male patients undergoing acute withdrawal from alcohol compared to controls. The more severe withdrawal patients showed a higher electric pain sensitivity. In other words, a lower pain threshold and thermal pain threshold. And their thermal pain threshold and pain tolerance correlated with depressive-like symptoms, as you see in the right-hand panel. And so the more depression-like symptoms they had, the more pain-like response they had during alcohol withdrawal. And I want to go back to the slide that I showed the first half of from Paula Park's PhD thesis. And I want to show you that we were able actually to challenge these animals with a single dose of heroin and show a hyperalgesic response, which we could also reverse with the CRF1 antagonist. And that's on the right-hand panel here. So you see the hyperalgesia, and that's reversed with a CRF antagonist. And more recently in my laboratory at the National Institute on Drug Abuse, we've been asking the question, can we see the same reversal of hyperalgesia with kappa antagonists? And I want to remind you that I showed that kappa antagonists could also block the escalation in heroin intake. So we designed a study where we looked at not only norBNI, but another compound that Phil Portuguese made called GNTI. Kenner Rice synthesized this with his group, and Dr. Salima. And we administered heroin every day, 2 milligrams per kilogram in males, 6 milligrams per kilogram in females. We got a hyperalgesic response every day. And then we did the same design that we did it with the animals that were escalating heroin intake. We gave one single long-acting injection of a kappa antagonist. And the results are equally dramatic as to what we saw with escalation. And you can see here in both the females and the males, we are able to reverse the hyperalgesia. Here's the baseline hyperalgesia. Here's the hyperalgesia before norBNI. But the norBNI reversed this hyperalgesia for 14 days in the males and 7 days in the females. And we used a mechanical hypersensitivity using, it was evaluated using the electronic Von Frey device, using the mid-plantar area of each hind paw. So how do I put all this together? Well, I put this all together to suggest that there is an overlap between the neural circuits of the dark side of addiction and the neural circuits that are associated with pain. We know classically there are two pain pathways. Spinal thalamic pathway goes from the dorsal horn to the periaqueductal gray, hypothalamus and thalamus. The somatosensory cortex rattles around up toward the frontal cortex, and eventually there's a connection to the amygdala. But there's another pain pathway that was identified by Jean-Marie Besson in Paris and Don Price at Hopkins that goes directly to the parabrachial nucleus to the amygdala. And if you overlap my beloved extended amygdala onto these pain pathways, the source of interface is in fact the amygdala. And I just want to show a couple of quick diagrams from Victor Nussbauer, who's been studying the nociceptive neurons within the central nucleus of the amygdala. And his argument is that there are inputs, nociceptive inputs from the spinal cord, as I just showed you, to the central nucleus, but there's also inputs from the cortex via the lateral amygdala, lateral part of the basolateral complex. And there are outputs from this nociceptive part of the central nucleus of the amygdala to autonomic nuclei in the hypothalamus, brainstem, spinal cord, but also back to the cortex. And Victor Nussbauer has shown in elegant studies that CRF antagonists can reverse the emotional part of pain when injected into the central nucleus of the amygdala. And so just to pull this all together, the argument is that during the development of addiction, there is a change in hedonic set point. And while we try to work our way back to homeostasis, as illustrated on the left-hand side of this slide, we actually end up in an allostatic state, a la Bruce McEwen and Sterling and Iyer. And we have a compensated equilibrium, an abnormal set point, and it's inherently unstable. And my argument is the opponent process remains, but the set point drifts further and further down. And these weights on the system, I argue, can be genetic and epigenetic. They can be environmental, such as childhood trauma. They can be other comorbidities, psychiatric comorbidities. But I want to emphasize the point, they can be just taking a lot of drugs. And in this case, since we're specifically talking about opiates, taking a lot of opiates. And we recently wrote an article commentary for the American Journal of Psychiatry, and we pulled this together to argue that this withdrawal negative affect stage of the addiction cycle, which generates hyperkatifia when you do a lot of drugs, can be influenced by these factors that I talked about, but perhaps is also exacerbated by the isolation and stress associated with the COVID-19 pandemic, possibly explaining why there's a soaring increase in opioid overdoses and a dramatic increase in drinking to cope that data are now bringing forth during the course of this pandemic. So this is what I've told you. Impulsivity, compulsivity, and loss of control in drug addiction represents a dysregulation of incentive salience, pathological habit, reward stress, and executive function systems corresponding to dysregulation of neurocircuitry with focal points in the basal ganglia, extended amygdala, and prefrontal cortex, respectively. Individuals with addiction are miserable and suffer a hypersensitive negative emotional state during acute and protracted withdrawal, a state called hyperkatifia. Loss of control in the dark side of addiction involves hyperkatifia-driven negative reinforcement via loss of function in reward neurocircuitry, but also a gain of function in stress neurocircuitry in the extended amygdala. Withdrawal from drugs of abuse causes pain, both physical and emotional pain, and significant overlap in the engagement of brain circuits mediating negative emotional states, hyperkatifia, and pain may be hypothesized to explain the role of alcohol and opioids in deaths of despair and the effects of social isolation caused by the COVID-19 pandemic. Thank you very much.
Thank you very much, Dr. Koob. Just as a reminder, please type some questions into the Q&A and we'll deal with them in the panel discussion